I'm Carlos Schenck from the Minnesota Regional Sleep Disorder Center and the University of Minnesota Medical School, and I'm located at the Hennepin County Medical Center, the public hospital in Minneapolis. I was born in New York City, went to Johns Hopkins University undergraduate, State University of New York at Buffalo Medical School, and then psychiatry residency at the University of Minnesota. And I then joined the staff as an assistant professor based at Hennepin County Medical Center in 1981. And then a year later, the chief of psychiatry at a staff meeting said, well, we have a newly formed sleep center being run by the neurology department, and they want a psychiatrist to be part of their multidisciplinary group. Any volunteers? And I was the only volunteer. Because I knew, based on my experience in medical school, that a lot of sleep medicine was really clinical neurophysiology, and neurophysiology really was my favorite basic science course. And so I said immediately, I want to be part of this exciting new field of sleep medicine. And as it turns out, my first day of practicing sleep medicine was September 11th, 1982. And the second patient that I evaluated was our index patient with REM sleep behavior disorder. So my entire career in sleep medicine has been wrapped up with RBD. But I have to pay great tribute to Mark Mahald and our original and great sleep technologist, who also is a registered EEG technologist, Andrea Patterson, because I spent the night of September 16th, 1982, 5 days after I evaluated our index patient who complained of aggressive dream and acting behaviors. And 5 nights later, I stayed all night in the lab, very curious about what he would have, because he was never a sleepwalker. He had no prior history of parasomnia up until a few years before. And when I saw him in the lab, every REM cycle, he was jerking and twitching his limbs, moving around, unprecedented. But what I really recall the most was the next morning, I saw Mark Mahald, my esteemed late colleague, an EEG specialist besides being a clinical neurologist. He and Andrea Patterson were challenging each other to say, this is not REM sleep. This is seizures. No, it's not seizures. And they kept coming up with alternative diagnosis. And at the end, they said, it has to be REM sleep. It was cyclical, it was associated with rapid eye movements, but the atonia of REM sleep had been lost. So I have to pay great tribute to Mark Mahald and Andrea Patterson, because they definitively said, this is a REM sleep disorder. Now, interestingly, Mark was a neurologist where they have a lot of movement disorders. So he initially called it REM movement disorder. And I said, look, Mark, I'm a psychiatrist. We deal with a lot of behavior disorders. This man is punching his wife. He's leaping out of bed. This is not a movement disorder. This is a behavior disorder. And ultimately, who decided the term was our sleep center receptionist and secretary, Susan Phelps. In our weekly staff meeting, she would print out, diagnoses for patients, and she finally said REM behavior disorder, and that's how it got resolved. But I understand Mark, because the field of neurology is full of movement disorders, and in psychiatry we have behavior disorders. But anyway, that's how we ended up naming REM sleep behavior disorder. Now, that was our index patient. It took us a few years to gather our first series of 5 patients. So then November of 1984, Bill Dement comes in to give a lecture. He was the greatest advocate of clinical sleep medicine. I mean, he was our hero. He had no loss of energy for just promoting the field of clinical sleep medicine. So he came in, and by then we had 5 patients. We showed in the video. And he was so excited, saying, these are Michel Jouvet's cats that we now find in humans. Because in 1965, the basic scientists Michel Jouvet in Lyon, France, had produced the first experimental animal model of RBD with bilateral pontine lesions in the pons. And these cats clearly were exhibiting what he called oneric behaviors, or dream enacting behaviors. And then, 20 years later, we found the human equivalent. And so that's why Bill Dement was so excited, saying, now I know who has Jouvet's cats in humans. So then fast forward to the following July of 1985, that was the first meeting where the APSS and the Sleep Research Society decided to join forces, and from then on have joint meetings that the next year was in Columbus, Ohio. So Bill Dement was so excited, he organized 2 symposia around RBD. I mean, the program had already been set, but Bill said, we got to put this REM behavior disorder on the program. And so I was twice invited to talk and just really demonstrate with video and PSGs the new condition called REM sleep behavior disorder. So Bill Dement, Mark Mahald, my heroes in terms of really getting the ball off the ground in terms of REM sleep behavior disorder. And then I had to bring in Bob McCarley from the Sleep Research Society. It's hard to believe, but the Society for Neuroscience actually had a meeting in Minneapolis. I mean, it's so enormous that it's only held in a few cities around the country, not including Minneapolis anymore. But there was a Society for Neuroscience meeting in Minneapolis, and I had written Bob McCarley, who was excited to hear about this dream enacting behavior. He walked over from the Minneapolis Convention Center and interviewed our index patient, Mr. Donald Dorff, and this was featured in the National Geographic magazine, December of 1987. And Bob was thrilled, saying, this is truly a dream enacting behavior. He looked at the PSGs and he said, yeah, this is for real. This is a REM sleep behavior disorder. And then he said, look, because of Jouvet's experiments in cats, you better look carefully for these patients having pontine or some type of brainstem abnormalities, and this is why they have REM behavior disorder. Well, as it turns out, our index patient had no neurological disorder. After many years of follow-up, I had the chief of neurology examine him very carefully, never found any abnormality. However, the other 4 patients in our initial series of 5 patients had diverse neurological disorders. So we finally published our series of 5 patients, and Bill Dement said, you have to send it to Sleep. And we said, okay, Bill. And so it was published in Sleep in 1986. And then in 1987, in the Journal of the American Medical Association, we published the first series of 10 patients. And the second 5 patients we had, 4 were idiopathic, 1 had neurological disorder. So the first 10 patients were equal, 5 idiopathic and 5 neurological disorders. We extended our findings to 1996, 38% of patients with idiopathic RBD converted to a Parkinsonian disorder. And then in 2013, it was an astounding 81% had converted to a Parkinsonian disorder, Parkinson's disease, or dementia of Lewy bodies. And that's when the outstanding group from Barcelona published their own series of 82% conversion rate from idiopathic RBD to a Parkinsonian disorder. And then the whole field exploded. We now have an international RBD study group with yearly symposia comprised of both clinical scientists and basic scientists. We've published more than 20 papers, and it's really a very active field of research, but it began at our hospital with Mark Mahal really solidifying that this is a REM sleep phenomenon, Bill Dement immediately recognizing the importance, organizing the 2 symposia at the meeting in July of 1985, and now the whole field is involved. I mean, there's something for everybody, I think, with RBD. Well, Mark Mahal is my longstanding dear friend and colleague who passed away, in 2018, or sorry, 2019. He was the co-founder of the Minnesota Regional Sleep Disorder Center and then became the director. And he was a very inclusive person. He wanted a truly multidisciplinary sleep center. And we had all the medical specialties related to sleep medicine, including dental sleep medicine, as part of our group. He organized Tuesday staff meetings, and we now called the Mark Mahal Tuesday staff meetings in his honor. And he always included as many people as possible. He was a dedicated educator. There was a medical student course involving sleep that he both lectured at, and then the clinical rotations, the students came to us. He was really tireless in lecturing around the country, around the world. He actually went to what was called sleep camp, the UCLA sleep camp, and he was the only clinician that was involved in the so-called sleep camp that was organized by this basic scientist at UCLA. They wanted to show their trainees, both PhD, postgraduates, and PhD candidates, about the relevance of their research in the clinical domain. And that's where Mark came in and really lectured on all the relevance of basic research to clinical sleep medicine. And he won all sorts of awards for public service, this American Academy of Sleep Medicine Awards. And so it wasn't just his scientific expertise, but actually his public service, his educational service. He did it all. I mean, he was the Renaissance man for the field of sleep medicine, sleep education, and sleep research. So I can't say enough about him. And he was just wonderful with me, very supportive of all that I did. And we collaborated on many projects and many manuscripts, and we truly never had any conflicts. I mean, he's the one who said that. I mean, it's true, but he was the one who said we never had conflicts. We worked very, very well together, and I really, truly appreciate him, and I miss him dearly, as the rest of us do. Well, Bill Dement, first of all, besides being tireless in promoting our field, he had a great sense of humor, too. And, every time I saw him, he would come up to me and ask how I was doing. He had a personal interest in what we were doing. And I mean, he was the poster man for our field of clinical sleep medicine. And you know, he ran that incredible course at Stanford for undergraduates on sleep that really is a legendary course. And people all around the country knew about that course, and they wanted to sit in if they were somehow near Stanford. They wanted to sit in his course. So he was a great educator besides being a researcher on narcolepsy. And he was very humorous in telling stories about his early days at the University of Chicago, how, you know, Nathaniel Kleitman would not give him his PhD until he passed his French class. And, you know, he was a raconteur to the greatest extent. And he entertained people. You know, he played musical instruments. He was a jazz master. I mean, he was a man for all seasons. I miss him dearly as well, too. Well, I've been involved basically in giving a lot of lectures over the years at the national meetings, being on committees. For example, right now, I'm on the parasomnia task force for the text revision of the ICSD-3, but I was also the chair of the ICSD-2 parasomnias committee. So I've been really involved with the parasomnias diagnostic classification system that is really monitored by the American Academy of Sleep Medicine. And I've been on various other committees as well, including also a lot of educational programs. And that's one of my major commitments as well, not just research, but the education to really help future generations become really interested in various aspects of sleep medicine, including parasomnias. Well, that was the original one. I was not involved in the original. I was involved in the ICSD-2. But that was a major revision. You know, we were blessed to have Peter Howry, who's another one of the major figures in the history of clinical sleep medicine. He was a wonderful man, and he died such a terrible, untimely death while walking his dog in snow, you know, in Rochester, Minnesota. It was just horrible. But he was great. I mean, he would joke around and say, you know, being the chair of the ICSD-2, you know, overall committee is like, you know, being a shepherd for cats. But I got to know, you know, all sorts of other people because I was the chair of the parasomnia section. But all the other chairs, like Phyllis Z, was in charge of the circadian rhythms section, and I got to know her very well. And so that was really an eye-opening experience to appreciate the contributions by the other specialists in different domains of the clinical field of sleep medicine. And we would meet regularly at a Chicago O'Hare Airport hotel. That was our place to meet and go over all the revisions. We had a buddy system. The buddy for me in the parasomnia section was Art Walters, who was in charge of the sleep-related movement disorder section. So we became very close and got to know each other. And through Art, I got to know a lot about sleep-related movement disorders. And through me, he got to know about parasomnias. But Peter Howry had the great idea of having the buddy system where people paired up. And so I was with Art Walters, and together we did the sleep-related movement disorders and the parasomnias and really helped each other out. Well, I think a big issue that still is a lingering issue is to what extent is like restless leg syndrome a legitimate diagnosis? In fact, and that's one of the reasons why, you know, the Willis-Ekman syndrome became the substitute name, which I don't think has taken hold nearly as well as they had anticipated. And I think, you know, the problem is not with the entity. I think it's a real diagnostic entity, but the overlap with many other types of problems. And to really delineate the specific core features. And also the lay public tends to kind of laugh at, oh, restless legs. So I think one of the major issues has been to further legitimize the diagnostic entity of restless leg syndrome, which it truly is, but it's really a very enigmatic condition in terms of its etiology even still. Well, I think an enormous issue, and I'm so delighted that the winner of this year's Sleep Research Society Outstanding Scientific Achievement Award is being given to Maiken Nedergaard for her seminal work on the glymphatic system. I think that's huge, and that is really the lymphatic system that exists in the brain. First discovered in 2012, and then subsequently, because of Maiken Nedergaard and her colleagues, we realized that it's sleep, particularly non-REM sleep, that activates the brain's waste disposal system. And if we don't get, and the research has shown, we need a minimum of 6 hours of sleep to let that waste disposal system work properly. And if it doesn't work properly because we don't get adequate sleep, in other words, 6 hours minimum, waste accumulates in the brain and that predisposes to dementia and other neurodegenerative conditions. And that's the seminal work of Micah Nettergaard and her colleagues. And I think, and already 2 papers have been published about REM sleep behavior disorder, having defective lymphatic system function, obstructive sleep apnea. And it's known now, there's a growing literature on how obstructive sleep apnea that's untreated is a risk factor for future dementia. The mediating mechanism could very well be lymphatic system dysfunction, that we don't have proper lymphatic function in the brain during sleep. And I think going forward, we have to educate primary care physicians, other physicians, and members of our own field that we need to have our patients sleep a minimum of 6 hours, sleep good 6 hours to really lessen the risk of future dementia. Well, Christian Guilleminault is another, giant in our field. And, he was always interested in everything. I mean, he was truly the Renaissance man as well in the field of sleep medicine. And he had a lot of keen insights into REM sleep behavior disorder, although that was not his primary interest. But basically, he was our go-to guy. If there was something puzzling going on, Christian would know. He would know the really arcane literature that was relevant to our purposes. So we utilized Christian and his really truly encyclopedic knowledge of sleep medicine and the published literature to really help us out with any unusual case and the background literature. Well, I already mentioned Peter Howry, that he was just tremendous, and he was one of the leaders for sleep hypnosis. For hypnosis for treating a variety of non-REM parasomnias, for example. And his work is still cited, and it's really a springboard for future research that's going on as well. The AASM is the outstanding leader of the field of clinical sleep medicine. It's a world leader. And it's really the focus of a lot of great education, public service, and I think it needs to grow and expand and really educate the public further. I should mention something else about Mark Mahal. I mentioned it, but I want to emphasize that I think moving forward, we need to really further underscore the importance of collaboration of clinical investigators and basic science research in the field of sleep, because they help each other out tremendously. I already mentioned how Mark Mahal really provided clinical relevance to a lot of the basic science research to further inspire the trainees. And I think clinicians need to realize that they need to know good research findings in the field of basic sleep research that can be applied to the clinical setting. So what I really want to emphasize is increased hybrid vigor between clinical sleep research and basic sleep research.